there! Baby Doc here with some sage advice for expectant parents and newborn healthcare professionals about renal tubular acidosis, RTA. Neonates can experience several types of renal tubular acidosis, ERTA, often due to the developmental immaturity of their kidneys or inherited genetic defects. The most common types seen in infants are proximal RTA type 2 and distal RTA type 1, while hyperkalemic RTA type 4 can also occur. The most common is proximal RTA type 2. This type of RTA in infants and young children and can be transient, correcting itself over time as the kidneys mature. This is because the proximal tubules are unable to reabsorb enough bicarbonate, leading to a buildup of acid in the blood and loss of alkali in the urine. This can occur as an isolated defect in newborns due to a lack of renal maturation, or as part of a broader disorder called Fanconi syndrome, which causes excessive urinary loss of other substances, including glucose, phosphate, and amino acids. Besides failure to thrive, infants may experience poor feeding, vomiting, polyuria, and hypotonia. In mild cases, the condition may resolve on its own. For more severe cases, treatment involves providing large doses of oral alkali such as sodium citrate. The next type of RTA seen in neonates is distal RTA, type 1. This form of RTA is typically permanent and often requires lifelong treatment. Hereditary distal RTA is caused by genetic defects that prevent the distal tubules from properly secreting hydrogen ions. Mutations in these genes can also cause sensorineural hearing loss. Infants with distal RTA may present with poor feeding, vomiting, polyuria, dehydration, and constipation. Later complications include nephrocalcinosis, calcium deposits in the kidneys, and bone demineralization, rickets. Early and adequate oral alkali therapy is crucial to correct the metabolic acidosis and prevent long-term complications like poor growth and bone disease. The least common type of RTA in neonates is hyperkalemic RTA, type 4. In neonates, hyperkalemic RTA can be caused by defects in mineralocorticoid production, as in congenital adrenal hyperplasia, or by a temporary physiologic resistance to aldosterone. The primary issue is hyperkalemia, high potassium, which can lead to potentially life-threatening dehydration, vomiting, and pulseless ventricular arrhythmias. Management focuses on controlling the hyperkalemia through diuretics or potassium-binding resins and addressing any underlying hormonal deficiencies. Diagnosis involves differentiating between the types of RTA, which involves a careful assessment of symptoms and specific laboratory findings. A persistent normal anion gap with metabolic acidosis is a classic sign. Additional blood and urine tests to assess electrolytes and check the urine pH helps differentiate between proximal and distal RTA. Genetic testing can be used to identify specific mutations, which is particularly helpful in inherited forms of RTA. Be sure to like and subscribe to McGlinn Institute Neonatal. And join me, Baby Doc, for more sage advice.